Welcome to this high-yield explainer. We're going to demystify oxygen therapy and arterial blood gases today, basically handing you the cheat codes for your MSRA exam. You know, if you've ever felt completely overwhelmed just staring at a blood gas printout, or maybe you second-guessed exactly how much oxygen to give a crashing patient, well, you are in exactly the right place. Let's get into it.
Here's our game plan for today. We're covering the physiology of gas exchange, type 1 versus type 2 respiratory failure, the British Thoracic Society oxygen rules, the ABG matrix, and we'll wrap it all up with the top 10 MSRA questions.
All right, Section 1, Physiology of Gas Exchange, the foundation.
Okay, so check out this crucial difference. Oxygenation, that's all about chemical exchange. But clearing out that acidic CO2, that depends entirely on the mechanical depth and rate of alveolar ventilation. So, oxygenation is measured by your PO2, right? In normal arterial blood, just breathing room air, we expect a partial pressure of 10 to 13.3 kilopascals. If that number falls, boom, you have hypoxia, a pure failure of oxygenation. But carbon dioxide, it isn't just a gas, it literally behaves as a volatile acid in your blood. You absolutely cannot chemically lower CO2 by just throwing more oxygen at the patient. It doesn't work that way. CO2 is cleared exclusively by effective minute ventilation. If you aren't physically breathing deeply and fast enough, that acid just gets trapped.
Moving right along to Section 2, Respiratory Failure, Type 1 versus Type 2.
The critical divide between these two failures really just comes down to your ventilatory pump. Type 1 leaves that pump totally intact. This actually causes low CO2 because the patient starts hyperventilating. Type 2, on the other hand, is a total ventilation failure, trapping that toxic waste gas inside. Let's break it down. In type 1, the PaO2 drops below 8.0 kilopascals, but because the lungs can still physically expand, the body's natural reflex is to hyperventilate. It's working overtime. This blows off the CO2, leaving it normal or even low. Think pneumonia or pulmonary embolism. Type 2, however, that's hypercapnic. Your PaO2 is low, sure, but your PCO2 climbs way above 6.0 kilopascals. Why? Because the mechanical pump is broken. Whether it's from COPD, severe obesity, or an opioid overdose, that alveolar waste gas is just accumulating.
Up next is Section 3, British Thoracic Society, or BTS, Oxygen Prescribing Rules. Now I need you to listen closely, because this is the single most important concept to take away from this entire explainer. The golden rule is this: hypoxia kills before hypercapnia. In a critical emergency, you must never, ever withhold high-flow oxygen just because you're scared of hypercapnia. Even if you know for a fact the patient is a chronic COPD retainer, if they are profoundly hypoxic, you must act immediately. Hypoxia will literally stop a patient's heart in minutes. Hypercapnia, that takes much, much longer to do any fatal damage.
You absolutely have to memorize these target ranges for the exam. Let's run through them. Scale 1 is 94 to 98%. This is for your acutely unwell patients who have zero hypercapnic risk, pneumonia, PE, that sort of thing. Scale 2 is a lot tighter, 88 to 92%. You reserve this for patients actively at risk of type 2 failure, so established COPD or severe obesity. But wait, here is the huge critical exception. If that known COPD patient comes in completely shocked, cyanosed, and their sats are sitting in the 50s or 70s, you completely throw Scale 2 out the window for a minute. You hit them with 15 liters per minute immediately via non-rebreather mask, grab an urgent ABG, and only titrate down after they're stabilized and that hypercapnia is actually confirmed.
All right, let's dive into Section 4, the Arterial Blood Gas Interpretation Matrix.
This matrix is basically a cheat sheet that beautifully categorizes every single acid-base disturbance you're going to see on the MSRA. Seriously, burn this into your visual memory. Let's trace a couple of lines together. High CO2 with a low pH and a normal bicarbonate? Well, that's acute respiratory acidosis, very often an opioid overdose. But what if the CO2 is high, the bicarb is high, and the pH is actually totally normal? That's your compensated respiratory acidosis. It's the classic stable COPD retainer. Their kidneys have essentially held on to bicarbonate to balance out that chronic acid. Conversely, if your main problem is a normal CO2 but a low bicarb and low pH, you're looking straight at metabolic acidosis, classic for DKA or sepsis. Once you understand these core relationships, you're going to instantly spot the underlying clinical cause every single time.
And finally, Section 5, the exam climax. Let's run through the top 10 MSRA questions.
Question 1. You have a severe COPD patient with an SpO2 of 58%. What is your immediate therapy? Going right back to our golden rule here, severe hypoxia trumps that COPD history every single time. A saturation of 58% is a critical, life-threatening emergency. You do not worry about carbon dioxide right now. You grab that non-rebreather reservoir mask, crank it all the way up to 15 liters per minute, and you stabilize their oxygenation first.
Question 2. What is the target oxygen saturation for a stable COPD patient? For a stable chronic retainer, we strictly stick to the scale 2 target, which is 88 to 92%. Why? Well, because they've actually lost their normal carbon dioxide-driven stimulus to breathe. They literally rely on mild hypoxia to maintain their respiratory drive. So if you over-oxygenate them to 98% when they're perfectly stable, you're going to knock out their drive to breathe, and they will accumulate fatal levels of CO2.
Question 3. Does increased FiO2 chemically lower arterial PaCO2? The answer is a hard no. And this brings us right back to our first physiologic dichotomy. Oxygen delivery cannot mechanically blow off volatile acid. The fraction of inspired oxygen, or FiO2, only fixes oxygenation. If you want to fix a high PaCO2, the patient physically has to breathe deeper and faster to eliminate that gas through alveolar minute ventilation.
Question 4. What PaCO2 finding distinguishes type 1 from type 2 respiratory failure? Simply put, PaCO2 is normal or low in type 1, but elevated in type 2. In type 1, the patient is starved for oxygen, so their brain tells their lungs to work overtime. Because the pump works just fine, they blow off massive amounts of CO2, resulting in a low or normal level. That reflex hyperventilation is the absolute hallmark of a pure oxygenation failure. In type 2, though, the pump itself is broken, so that CO2 inevitably rises.
Let's look at question 5. Heroin overdose. pH is 7.15, PaCO2 is 8.5 kilopascals, and HCO3 is 24. What's the diagnosis? It's acute respiratory acidosis, and it's uncompensated. So the depressed ventilatory drive traps the CO2, crashing the pH way before the kidneys even have time to react. Heroin is an opioid, right? It suppresses the brainstem's respiratory center. The PaCO2 shoots up to 8.5, well above normal. And because this is an acute situation, the bicarb is just sitting there at a normal 24, leaving the pH dangerously acidotic at 7.15.
Question 6. You have a stable, severe COPD patient. pH is 7.38, PaCO2 is 7.2, and HCO3 is 34. Why is the pH normal? It's because of renal compensation, specifically metabolic alkalosis. Unlike the acute overdose we just talked about, this is the classic retainer profile. Notice the high PaCO2 of 7.2. Normally, that would cause an acidic pH, but since the COPD patient has dealt with this for years, their kidneys have fully adapted through metabolic alkalosis. They're retaining enough bicarbonate, sitting up at 34, to perfectly balance the blood pH right back to a normal 7.38. Pretty amazing, right?
On to question 7. What is the target SpO2 for a healthy young adult with pneumonia? With no underlying hypercapnic risk, we aim for the standard scale 1 parameters, which is 94 to 98%. This patient has completely normal baseline lung function, meaning their ventilatory pump is entirely intact. There is absolutely no risk of them suddenly retaining CO2 just because you give them oxygen, so we confidently target a nice healthy 94 to 98%.
Question 8. What is the initial delivery device you use to titrate a stable COPD patient to 88 to 92%? The answer is a 28% or 24% Venturi mask at 4 liters per minute. Guys, the Venturi mask is your absolute best friend here. It's an insider secret you've got to remember for the wards, because it delivers a highly precise fraction of inspired oxygen. Unlike standard nasal cannulas, where the actual oxygen percentage fluctuates depending on how deeply the patient inhales, a Venturi mask uses these specific valves to guarantee exactly 24 or 28% oxygen. This allows for super safe, controlled titration in sensitive COPD patients.
Question 9. Why is standard pulse oximetry dangerous in carbon monoxide poisoning? Because it cannot distinguish oxyhemoglobin from carboxyhemoglobin. This is a classic exam trick, and honestly, it can be fatal in practice. The pulse oximeter will falsely reassure you with a high reading, despite severe tissue hypoxia. Standard oximeters only measure light absorption to see if the hemoglobin is bound to something. They have no idea if it's bound to life-saving oxygen or deadly carbon monoxide. So your machine might read 100% saturation while the patient's cells are completely starved of oxygen.
And our final question, question 10.
A COPD retainer's pH falls despite controlled oxygen. What is your next step? You move to non-invasive ventilation, like NIV or BiPAP. When controlled oxygen just isn't cutting it and the acidosis is worsening, you have to step in and take over the mechanical work of breathing. This scenario is called acute on chronic respiratory acidosis. The patient's pump is failing, the CO2 is building up, and that pH is dropping fast. Because oxygen alone cannot clear CO2, you must introduce non-invasive ventilation to mechanically push air in and out, forcefully blowing off that toxic volatile acid.
You now have the exact physiological frameworks and prescribing rules to completely conquer the MSRA and dominate on the wards. But look, the real test isn't on a piece of paper. When that critical patient crashes through the doors and their saturations are dropping by the second, will you trust the guidelines, or will you let fear delay life-saving oxygen?